Hey guys, what if I told you there was an easy way to hack the EKG so you would never have to be afraid again of reading them? In fact, not only would you not have to be afraid, but you might even look forward to reading them. Sounds kind of crazy, right? Well, I used to be in the same position where I hated EKGs. I started out as a paramedic and I was terrified of the tones going off. I did not want there to be another EKG for me to read because I didn't feel equipped and I didn't feel comfortable. And so that drove me to be afraid enough to learn the things I needed to know. And now I work as an ERPA and a cardiology PA. I learned a few things along the way that I'm going to share with you. In fact, I'm going to share with you 10 hacks today where you can start using them tomorrow and you'll instantly feel better about the EKG. So I'm going to show you some insider's secrets on what you can do to not let the EKG get the best of you. And guys, this is just the tip of the iceberg because there is a lot more where this came from. So if you end up liking this little mini lecture, make sure to join me at one of the conferences near you at the Skin, Bones, Hearts, and Private Parts in the summer and in the fall. So who am I? Again, my name is Jen Carlquist and I work in the emergency department. I work in cardiology. Here's me doing a stress test. And I also lecture across the country. I've been a PA for 13 years. And before that, I was a paramedic for 13 years. So I've had a lot of chance to look at EKGs and be afraid of them, but also now feel fairly comfortable with them. And believe me, I was the girl who sat in the back row and I didn't want to be called on because I was too afraid that I would get the answer wrong. Because I've been there, I'm going to show you the way how to climb out of feeling that anxiety and fear over the next EKG coming across your desk. So hack number one is know what normal is. So we're going to cover this on an actual EKG in the next slide, but the first thing you should know is that the EKG is like a family, and the P wave is the mom, the QRS is the dad, and the T wave is the baby. And when you know that, you know what to look for, meaning the whole family should be holding hands. And I'll show you what that means in a minute. You also want to use the numbers at the top of the EKG because as it turns out, they are actually important. And believe me, for a long time, I didn't know what those numbers were on the EKG for. I thought, oh, are these here for the cardiologist? But it turns out there's some clues that lay in the intervals that can be really helpful, especially with patients with palpitations. You need to know which way the T waves should be pointing. So for example, they should all be upright except for in leads AVR and V1. They should be inverted and that would be normal. So knowing that out of the gate sets you up to win. And then the other thing that can be super helpful when you look at an EKG is to know if the voltage is low or high. Because if it's low, you may be dealing with an effusion, a pericardial effusion, for example. And if it's really high, you may be dealing with something called left ventricular hypertrophy. So let's talk about this EKG and why this is normal. So the one thing I just want to get out of the way is that the EKG, a lot of times will just say normal ECG, but it won't be right. About 50% of the time it's actually incorrect, which means that that can lead you astray. I've seen a Brugadas, which is a very bad thing that leads to sudden death in young people. I've seen that be read by the machine software as normal. Clearly it wasn't normal. He had a cardiac arrest and survived, by the way, which was good. But on the normal EKG, the closer the EKG is to being normal, the closer the machine will have a chance of getting it right. So looking at this, talking about the family like we just did, the P wave here should be really nice and round. It shouldn't be humped or notched. The QRS or the dad should be nice and skinny. And then the baby should be nice and close to his dad. And he shouldn't be pointing down in any of the leads except for the two up here, AVR and V1. That's where it should be. The T waves should be pointing down, and they are. All the other T waves, if you march through them, they are all pointing up, which is good. The next thing you want to look at, you'll usually have a rhythm strip at the bottom of the 12 lead. And what you're going to do is you're going to look for the R to R interval. And when you look at that, you're going to make sure that it's regular, meaning it's coming at the normal expected next time. Okay, so every family should be marching together, and you're also going to dissect these intervals for clues. So speaking of intervals, let's talk about them for a second, because here's the problem. You get intervals, for example, a reference range, With lab values, they'll give you a little parentheses next to the number and they'll tell you what normal is, but they don't do that for the EKG. So what I did was I made you a little cheat sheet, and looking at these numbers, these line up prospectively to each number. So for example, let's go through these together. This is the ventricular rate, which is also known as the heart rate. And this should be between 60 and 100 beats per minute. This is something we all know, but it's just nice to see the reference range here. The next thing is the PR interval. That's the time it takes for the impulse to go from the atrium down to the AV node. The next line down is the PR interval, and that should be anywhere from 120 or to 200 milliseconds. So looking at this, with it being 150, it is between 120 and 200. So that's a normal PR interval. This can be helpful when you have a Wolff-Parkinson's White patient. If this is short, less than 120, you have to alert your brain to go back into the EKG and look specifically for delta waves that are associated with Wolff-Parkinson's White. So this is just one way those intervals are helpful. The next line down is the QRS duration, and that's 76. It should be below or less than 120. And you can see when you look at it that it will be skinny. So the DAD is very skinny, and that's what we want. This being 76, that's normal, right? Because it's less than 120. The next line down is the QTC. That is the corrected QT interval. That number is 446, which is normal because it should be less than 460. Anytime it's over 460, that's technically prolonged, and you want to watch out for things like torsades. And then finally, the next line down is the PRT axis, and 51 here, this is actually normal because normal axis is between 0 and 90. Now, if any of you are shaking your head or tearing your hair out when I say the word axis, don't feel bad, because I did this for a long time too. And axis is really a tricky thing, but the good news is that if you come to the workshop, I'll be giving you an easy cheat sheet that you can use for axis. But the thing about axis is that it's not always necessary to have it. So it's helpful in times where you think you might have a pulmonary embolus or you have a wide complex tachycardia. Those times it's helpful, or a respiratory patient. But other than that, it's not that helpful, and we don't really rely on it for many treatment decisions. So if you had to spend any time on anything at all, I would say don't spend your time on axis, because you could better spend it on learning things like non-specific ST2 wave changes, which I'm going to talk about in a minute. So let's practice using the intervals for a second. Now, if you look at this here, this is clearly saying it's a Wolff-Parkinson's White, which we have to look out for delta waves here, right? So let's go into the EKG and let's do that. So you can clearly see that there's delta waves here, and that's what they look like. There's a nice upstroke or slurring of the QRS complex. You can see it in multiple leads here. And that's just happening because there's an accessory tract that goes from the sinus node to the ventricles. So it makes a slur because it's not going through the AV node where things normally go. And like I just said, there's some clues here. And the clue here is that you have a PR interval of 88. And as we saw, anything under 120 is short, and short PR interval will have to worry about Wolff-Parkinson's White. So this was a good example of that to show you. And there it is. All right, now this is a 50-year-old who came in with palpitations, and here's your EKG. So the big question in your mind should be, what is it? What's the rhythm, right? So you have to kind of dissect it. You have a rhythm strip down here in V1, and if you look at the R to R interval, you can clearly see that it's not regular. And when it's not regular, it's irregular. And so when you look at it, is there any pattern to the irregularity? For example, could it be a heart block with some drop beats? There really isn't any pattern. This is definitely irregularly irregular. And when you have something that's irregularly irregular, this is none other than the meat and potatoes rhythm we see all day long, AFib. But this is AFib with rapid ventricular response because it's over 100. So with that being said, if you were thinking that this was possibly SVT, right, or sinus tach, the way you would know is by looking at the PR interval, because if it's sinus tach or if it's SVT, it's usually not going to have a PR interval asterisk. So I like to call this the star of AFib because it's super helpful. In case you're thinking something might be regular when it's fast, because it can be confusing, you can just go back to your star and check it out, okay? And here's another great case of someone who was 37 who complained of feeling weak, came in, and the nurse noted that there was a high heart rate. So they got a quick 12 lead, and you can see again that this is definitely irregular. You have your rhythm strip here, your R to R intervals irregular, and of course here you have your star of AFib. And you can see that this is AFib with RVR, or rapid ventricular response. So this is another reason that we look at the interval numbers here because of a case like this. So this patient came in cardiac arrest, was actually resuscitated, and successfully survived. And the machine said, right after she got her shock and was resuscitated, the machine said that she had a non-specific T-wave abnormality. Now I'm going to talk to you about why this is like one of the worst things the EKG can say, because all the really big bad wolf things that are not a STEMI hide in non-specific T-wave abnormality. So it's something that we don't want to miss. But what was going on with her, and why do you think she went into cardiac arrest? Well, it was clear on the EKG and after they did all the testing that it was due to prolonged QT. And you can see if you look at her QTC, it's 528. That is definitely longer than 460. And when you get over 500, that's when you usually start seeing things like torsades de pointes, which is a lethal form of VTAC. And it was so long, the machine even called it prolonged QT, which is very rare. The machine will pick it up for you. That's why we have job security, which is good in times like this, but also kind of scary because the machine we thought was supposed to help us, because we're taught, well, computers are smarter than us, but not always. And that's why we have job security. Hack number 2 is recognizing hyperkalemia. Now we know about the peak T waves. We learned that, but also you'll see sometimes bradycardia. Sometimes you'll see the P waves disappear. Sometimes you'll see a wide QRS. And a lot of times you'll see a prolonged QT. So how would this be helpful to you in clinical setting? Well, this will be helpful for you if you work in the emergency room for sure. This would be someone that you'd want to jump on, right? There's a heart rate of 27 and check a pulse. Absolutely, right? That's the first thing. And then the second thing is, do they need to be paced? The third thing would be to get an I-stat potassium, right? If that was possible. But if you're in the clinic, well, the good news is you just have to call 911. So you don't have to sort it out. But let's just say we took a stab at it and sorted it out together. What we would find is that the patient was not only bradycardic, but there's no PR interval because the P wave is hardly detected. Honestly, there is a P wave here. This is more like a sinus brady. You can see the P here. You can see it here. But it's really hard to discern. And if you called this an idioventricular rhythm, I don't think you'd be wrong, because really the underlying thing is they have hyperkalemia, and that's what's causing this to look like an idioventricular or a really slow sinus brady. And so with that being said, you need to fix the problem, right? And that would be hyperkalemia. So other clues, we would have seen this right off the bat, is the peak T. Totally would have seen that. We would have seen the wide QRS, and we would have seen no P wave. But just in case you wanted to put the whole thing together, this was actually a patient who came in weak. And I got to say that weak is one of the most challenging complaints because there's so many things that could be wrong. But this patient was particularly outdoors on a hot day and had taken a bunch of Motrin and then didn't hydrate. And so they had acute kidney failure. So with that being said, you can kind of put it together that their potassium was sky high, and as soon as their potassium was treated, they no longer had an EKG that looked like this. All the QRS is tightened up and the heart rate came up, but this was something that you wouldn't want to miss, right? And if you're in the clinic, you want to have access to stat labs. Not that it would make that big of a difference here, but I think that realistically, just knowing the peak T is not enough. You need to know the other findings, because the more tools you have in your tool belt, the better off you are. The other thing to know that is a hack is know the location. And what I mean by that is that you want to know the location of the artery that's feeding each wall. And so when you have somebody who comes in with an anterior MI, which is here, they're going to usually present high and fast. That means their blood pressure is going to be high and they're going to be tachycardic, because they're basically stimulating the fight or flight reflex when you're attacking the coronary artery that feeds the main pumping part of the heart. And then you've got the right coronary artery that feeds the inferior wall, and a lot of times patients will come in low and slow, which means they'll come in bradycardic and hypotensive. And this kind of just gives you a clue of what you should anticipate. because if you have an inferior MI, a lot of times it'll take out the sinus node and you'll get sinus pauses. And that would be a good thing to know so you could have the pacer ready, right? The transcutaneous pacer ready. So anticipating the problems is important. And as I just mentioned, I wanted to bring this home for you that a right coronary artery lesion will often show up with a sinus brady or a junctional rhythm, because again, the sinus node just is not being fed and it gets ischemic, or the lower degree blocks like the first degree and second degree, type 1, also known as the Winky block, which is incidentally my favorite rhythm. Also, you might see with an LAD, the higher degree blocks, so the second degree type 2, otherwise known as the Mobitz, or the third degree AV block. You might also see new bundles form. And so when you see new bundles form, it's always concerning for ischemia. This is actually from ekgtools.com. This is a nurse practitioner that made this graph, who put this together, which I think is just a brilliant description of what you should anticipate. The next hack is honoring thy T-wave. This is a great mugshot, so to speak, of all the T-waves that should be in jail. Not really, but I mean, this is all, it's like their mugshot. So if they were wanted, this is what we would put up in their little jail poster. So the things that the machine will call non-specific ST-T-wave abnormalities are listed here in a group. There's actually more of them, but I love this graphic. This is from a book called The Art of 12-Lead Interpretation by Dr. Tomas Garcia, and it just summarizes all the big bad wolves in the T-wave world so well, I had to throw it in. So what you'll notice here is a biphasic T-wave. Any biphasic T-wave is concerning for ischemia, right? Anywhere it is, you should worry about it. Anything that's broad or flat usually means hypokalemia, which makes sense when you know that peak T waves represent hyperkalemia. And then you should have an eye out always for any ST elevation, which you see here. But this can fool you, this benign early repolarization, into thinking that it's a STEMI. And there's a way to look at this to know it's not a STEMI and to not be fooled. And then you should also look for T waves that are inverted. Now, if they're inverted anywhere but AVR or V1, that's a problem, and especially if they're symmetric like this. If they're symmetric and inverted, that's a big bad wolf and means ischemia till proven otherwise. There's actually 3 other things it could mean, but it's usually ischemia, versus the left ventricular strain T wave that you will often see. And here it is right here, where you've got your QRS, and then it comes down into like this reverse check mark situation. This happens when your ventricle gets too big. And when your ventricle repolarizes, it will repolarize different and causes a strain pattern. This is not an ischemic change, rather it's a change of just the cells repolarizing differently. And then finally, prolonged QT interval. The way to recognize that is the baby is getting really far away from the dad. The next hack would be anxiety is a diagnosis of exclusion. And I can tell you, I've seen so many patients, this was one of them, who was sent in with a diagnosis of anxiety or had been labeled with that in the past. But when you really drill down and ask them about their anxiety only lasted a few seconds. So 30-year-olds with palpitations, a lot of times we do think about anxiety, and it is the most likely thing. However, the way to not get caught with your pants down, so to speak, to not get burned, is to think worst first. And this was a case of somebody who came to the office and had been written off multiple times, but because she persisted to complain, they sent her in for a stress test and Holter monitor. So as we were hooking her up for her stress test, this is what we found. And this is a run of VTAC here. And what's a 30-year-old doing with VTAC? It's not the first thing that would come to mind, but it turns out that she ended up getting a VTAC ablation, and she's doing great now and no longer needs to be on an anxiolytic, which she didn't even really need in the first place. She just needed her VTAC to go away. So anytime somebody says to you, hey, my anxiety just lasts a few seconds, or I feel like I'm gonna pass out, and they're not hyperventilating, then we always wanna think about arrhythmias. Actually, we always wanna think about arrhythmias, right? Because we don't wanna miss this and write them off. This is another 30-year-old, speaking of 30-year-olds, who had palpitations. And you can clearly see that her EKG is abnormal. And the concerning thing here is that it's a wide complex tachycardia. So this is actually one of the times where axis comes into play. When you have this wide complex tachycardia, you're kind of hoping that the machine will tell you that, hey, this is VTAC, because that's always the question in your mind. The question is it VTAC or is it SVT with aberrancy? which means SVT that's taking a different pathway down the heart's conduction. But the fact is, that's a really, really hard call. And one of the tools that you'll have, and you can see the machine's not helping, it says why QRS tachycardia, but one of the tools is Axis. So a really quick way to help you lean towards the diagnosis of VTAC is this. In lead 1, 2, and 3, lead 1, 2, and 3, if the QRS is pointing down in all leads, which it is here, it's most likely VTAC. There's a lot of other different ways and criteria, but the reality is there's really no one criteria that's 100% for this. So that's why Axis is just one of your tools in your tool belt when it comes to this. Now, again, if this is in your office, right, it's an easy thing. I don't need to figure out what it is, but here's the thing. You're gonna have to call, if you're in the clinic and you're working urgent care or family practice, you're gonna have to call the ER and give a report. And you're gonna have to say, hey, I have A, but let's just say you didn't know what this was and you weren't sure and you just didn't feel confident enough. That's okay, because if you're ever in that position with an EKG, all you have to do is just get on the phone and describe it. So what you could say is, hey, ER doc, I'm sending you a 30-year-old female who has a wide, complex, regular tachycardia. And then it's easy, right? Because then they just have to basically can guide you through the decision making, right? And so it's a lot of times going to be an SVT with aberrancy, especially in her age group. But it turns out that 85% of the VTACs, or 85% of the wide complex tachycardias are VTAC. So you actually have a really good chance of getting it right if you guessed VTAC. Number 7, don't ignore the voltage. And what I mean by that is, don't ignore the size of the QRS complex. And you can see here that the QRS complex here looks normal. But then the very next beat, it's actually smaller. Very next beat normal, next beat smaller. Next beat normal, next beat smaller. And so what's happening here is two things, okay? The size of the amplitude is varying. And what this is called is electrical alternans, because it's going up, down, up, down, up, down. And when it does that, it's actually caused by the heart swinging in the sac. And it's doing that because there's a bunch of fluid in the sac, and the heart's pericardium is not supposed to have a ton of fluid. So this alternans is important, but the other take home is this. Whenever you have a low voltage, and you can see that there's low voltage here, especially in AVL, but if you have widespread low voltage and tachycardia, you should always think about pericardial effusion. So you definitely wouldn't want to miss that. And I'm going to show you an interesting case. So this is a 45-year-old female who experienced dyspnea on exertion for a month. So she thought that, maybe she was just out of shape because she wasn't riding her bike as much. And she noted that she was able to ride her bike at higher speeds prior, but now she was only able to go like 6 miles an hour, 7 miles an hour, when she was doing 15 or 16 before. So it's a big drastic drop, right? And you always want to quantify when you're talking about activity levels, how is this different from before? And then now she says, well, now I'm just short of breath walking across the hall. A 45-year-old female should not feel that, right? So you'd inquire about the normal things like, do you have chest pain? No. Have you been on a flight recently? No. Do you have lower extremity edema? No, right? But you'd also want to think about anemia, especially in a menstruating female. So you get a hemoglobin, it's normal. You get a creatinine, it's normal. There's no renal failure. You get a thyroid, because you're always thinking about mixed edema, and maybe, that's why she's having this dyspnea. It's possible. You get a glucose. It's a little elevated, but it's not fasting. So can we really rely on that? No. And would it really be relevant? Probably not, right? ESR, CRP are normal. And then, because you're always thinking about coronary artery disease, you get an EKG, but she does tell you that she had a calcium score 4 years prior. And that is important in the story, because that means that it's very unlikely that this is actually acute coronary syndrome, because a calcium score being fairly clean, meaning that they looked at her coronary arteries with the CAT scan, it's unlikely it's ACS. So you get an EKG, here it is, and you have to sort out what's going on here. So they're a little bit bradycardic. She is bradycardic a little bit, but you know what? It's not marked bradycardia. And if she's riding her bike, that's probably okay. And then you have a low voltage QRS. And so you can see the machine's even calling it, which is actually pretty rare. for the machine to call it. But if you look here, you can see that this family, this is where the family analogy comes in. You can see the P wave, the QRS, and the T. The QRS is really small. The QRS shouldn't be small. And in V4, it's almost flat. And even where it is present, it's not really that big. And you can see in AVL, it's also small. So with all that being said, we have to worry about something getting in the way. The something getting in the way is here. So this is her echocardiogram. And as you can clearly see, there is something very wrong. Now, just to orient you to what you're seeing here, this is the left atrium. This is the left ventricle. And this is the right ventricle, which is actually being collapsed. That's why it's so small. And this is the right atrium, which at some points was actually buckling. So, and then just to show you the pericardium here, the pericardium is actually thickened, and that's why it's white. So we didn't see any signs of pericarditis, but she did have pericarditis. And then here you can see a ton of black, and that's not supposed to be there. So this is fluid that's collecting between the pericardial sac and the ventricular wall. So it's basically suffocating the heart. This was a pericardial effusion. So what did she need? She needed to get the fluid out from between the pericardium and out of the pericardium. She needed to get, so what does she need? She needs to get the fluid out of her pericardium. So we did an echo that was official. It was red and showed what we just saw, which was moderate circumferential pericardial effusion. And you can see that the right atrium, I always love when they write this, does demonstrate. The atrium is demonstrating? Okay, but it's funny. I like it. Some diastolic collapse, as does the free wall. So in diastole, the right ventricular free wall and the right atrium were collapsing. So that's borderline tamponade, which is really, really bad. So this patient's very sick, needs to get either a pericardiocentesis or a pericardial window, which is where they take a patch out of the pericardium so the fluid can leak out, which is what she needed, and she's doing well now. No longer has any dyspnea on exertion. The next tack is always assuming the worst in a wide complex tachycardia. So what does that mean? That just means that whenever you have an EKG that has wide complexes and it's tachycardic, it's best to err on the side of ventricular tachycardia, even if they don't follow the rules, the QRS complexes. They don't follow the rules that I told you earlier in the other EKG, where the QRS is in 1 and 2 and 3, even if they're not all pointing down, which is, you can see in 1 it's not, in 2 it is, and 3 it is. Even if they're not all down, it still has to be VTAC until proven otherwise. This was a 55-year-old male who came in who got shocked by his ICD. That's a clue right there. If somebody has an ICD in their chest, they have it in there for a reason, and it's not for SVT. So, and this patient ultimately had a low ejection fraction, and anything under 35 is at risk for ventricular tachycardia, which this was. So the question then becomes, why isn't the device shocking him when it's VT? And it's because his heart rate was too slow for the machine to know to shock him, because it usually shocks 150 and over. So it still is VTAC, even if the device isn't shocking them if they come in at a low rate, which is a little insider's tip and trick. Number 9 is don't be fooled by the STEMI imposters, because there's a lot of them out there and they are just waiting to bite us. So we have to know the difference between a STEMI and not a STEMI. So we have to know first that with STEMI, you need to have 2 leads that are contiguous with ST elevation and 2 leads that are reciprocal. So what does that mean? That means 2 arteries that are fed to, so what does that mean? That means that we have 2 leads fed by the same artery and then a mirror ST depression in the other leads. So here you can see a ton of ST elevation all over the place. In fact, this looks really odd, right? And so what was happening here is this patient was actually left outside. They had had too much to drink. It was the winter. They were asleep on the concrete outside of the bar, and it was like 2 in the morning. And so when EMS was called, they promptly responded, found the patient to be very cold, and the patient had a very, very low core temp. And so this was actually caused by hypothermia. The machine will sometimes call this a STEMI, but it's not. And so you have to not be fooled. Otherwise, you could activate the cath lab. And for a hypothermic patient, right, you wouldn't want to do that. So here's another example of a STEMI mimic. And this is where the machine actually got fooled, which is again why we have job security, which I'm so happy about. So what you can see here is the machine is calling it a STEMI. So we have to make a decision. Is it a STEMI? Is it a STEMI? We've got to call the hospital if we're in the clinic, or we got to call the code team if we're in the hospital. So we need to know what to do. And how do we sort this out? Well, here's what we do. We look at the EKG and we say to ourselves, I know that STEMI criteria means I have to have 2 up and 2 down. So do I have 2 up? Let's go see. Yes, this is up. Yes, this is up, meaning ST elevation. Yes, this is up. Yes, yes, yes. In fact, all of the ST segments are up, right? And there's nobody or no depression at all in the ST segments. So when you have that, you have to think about the other things, because you know STEMI has 2 up and 2 down. One of the other things would be pericarditis. One of the other things would be benign early repolarization. And they create an ST segment that looks more like a smiley face, where you could almost picture 2 eyes and a little smile here, because they're smiling because they're not a STEMI. Okay, so you have to know these really fine details to not get burned by the EKG software. And that's why, again, we have job security. And then finally, I think this is the most important thing, is knowing your non-specific ST wave changes. So the machine will oftentimes say this in the read, and you have to know what to look for. And I'm going to show you an example of something that was read that way that was really bad. Great case. This was a 64-year-old male who presented to the clinic for a nurse visit. So just to get an EKG, because he had been having chest pain. Now, mind you, the nurse had told him, go to the ER multiple times, but he didn't want to go to the ER, as a lot of people don't want to do, even when there's not COVID. So he didn't go to the ER. He suffered 3 days through some excruciating pain that was finally not being relieved by the nitro anymore. So we always tell patients, right, if you have 3 nitro and your pain is still not getting better, then it's time to call 911, right? And you should be thinking about it after maybe the 2nd nitro. But this gentleman had pain so long that the nitro wasn't relieving it anymore. So he actually admitted, I've actually been having chest pain for a week. And when it comes and goes, it's called stuttering chest pain, which is not good. So his history was that he had a stent placement done previously. In fact, he also had a history of a renal transplant. So this is someone that you don't want to mess around with, right? Because they have already proven that they have disease, that they're a disease former. So here's the EKG, and you can clearly see that it says that thing I love, ST wave abnormality, consider lateral ischemia. Well, here's the thing. So yes, it is saying that there is an abnormality. Lateral wall, which is over here. The T waves are down where they shouldn't be down, right? They're inverted. Where they should be inverted is here and here. And yes, AVR is inverted, so good, but the V1 T wave is not following the rules. He's up when he should be down. So that is one of the problems. But remember when I told you guys about the biphasic, the T wave that goes up and down, whenever you see that, it's a sign of ischemia. This is definitely the case. So now we have 2 clues, but also there's actually another clue. And the other clue is something that is a very hard thing to learn, but it takes appreciating the eye, and it takes remembering the family analogy, which is why I think it's so helpful. When you look here at the QRS and then the T wave here, you can see that the baby is pretty tall. When your baby is tall in just 2 leads like this, what that's called is a hyperacute T wave, which just means it's big. When a T wave is big, you always worry about ischemia. Now, you're asking probably in the back of your mind, hey, I was learning in school that if I have big T waves, it's most likely due to hyperkalemia. How do you sort out if this is hyperkalemia or if this is just a hyperacute T wave? So hyperkalemia T waves will come all throughout the EKG. They will not just be isolated to where one lead feeds them. So the lead that's feeding them, right, the LAD, or the artery that's feeding them, the LAD, all the leads that look at the LAD are having issues. So V1, 2, 3, and 4 are all having issues. And that just supports even more that this patient needs to go to the cath lab. So what ended up happening to him? Well, unfortunately, he had a stress test for months prior, and he never followed up. So he actually had a significant abnormality. And as you can see, what the most important part here is he had a resting ejection fraction of 50%. But during stress, it went down. And when it goes down this much, it's usually a sign of multivessel disease. So he goes to the emergency room because his 5 nitro were not helping. He gets sent from the cardiology clinic, and his troponin is up. and then continues to go up, and then markedly goes up. So he's actively infarcting while he's in the emergency room. So it's really good that he went. His GFR is not so good. It's 39, which is bad because unfortunately he has only one kidney, right, from a kidney transplant. And so we definitely do not want to hinder that kidney in any way. However, what do you think we need to do? We need to send him to the cath lab, which is going to introduce him to contrast load, which is going to be hard on his kidney. Now, he doesn't have a lipid panel done because you're in the ER, and you don't get that when you're in the ER. And his CBC is normal, which is good. And his post-operative diagnosis, when he goes to the cath lab, he comes out with 2 stents. So he not only got a stent in the LAD, he also got one in the circumflex. And the LAD was 95% occluded, circumflex was 100% occluded, and he got DES deployed, which just means drug-eluting stent. The diagnosis was acute myocardial infarction. We could see that because the troponin was going up, and coronary atherosclerosis. So he gets admitted, rightfully so, and it's time to start him on some therapy. But the next day, he has more chest pain. And unfortunately, he has to go back to the cath lab again because his EKG is very abnormal. And it turns out that he re-occluded his stents, and both of them. But only one of them, the LAD, could be opened. And unfortunately, that did a lot of damage. And then his ejection fraction went down to 20 to 25%. So unfortunately, now he's at risk for what big bad wolf? He's at risk for a VTAC. And we know that, so we should protect him from it. So what should we be thinking about? We should be thinking about an AICD. However, we can't put an AICD in him yet because he is revascularized. And whenever someone gets stents or revascularized, they have to wait 40 days before you can redo an echo to put an ICD in because half of the patients will improve. So because we don't know if he's going to be that 50%, and we do not want to put a machine in him, device, if we don't have to, we can protect him with something else called the life vest in the meantime. But he's still in the hospital. And unfortunately, before he could get his life vest placed, he actually goes into collapse from ventricular tachycardia in the heart center. And unfortunately, he was resuscitated, but he was discharged with contrast-induced renal nephropathy, which is unavoidable by his 2 caths, and his prognosis was really guarded. So luckily, he survived, but time is muscle, and that was really a good case to. So thank you for your time and attention. I've enjoyed sharing my 10 EKG hacks, which are basically tips and tricks, how to not be so afraid of the EKG, and hopefully you feel a little less intimidated. But if you want more, I'm coming to a city near you at the Skin, Bones, Hearts, Private Parts Conference, and I would love to meet you in person and do this live where I can actually walk you through my workbook and walk you through 17 sample EKGs where we'll actually write on them together, we'll color code contiguous leads, we'll color code reciprocal changes, and we'll do all that within 2.5 hours. So give me 2.5 hours and I will give you major EKG confidence. Anyway, thank you so much, guys, and I hope to see you soon.